and welcome to today's presentation on serving healthcare clients with limited English proficiency. My name is Tina Quibley, Marketing Director for Pacific Interpreters in Portland, Oregon, and I will be moderating our event. In this presentation, we will identify who we are serving and the challenges they face in accessing healthcare. You will learn about federal laws that relate to providing services for limited English individuals and hear best practices for working with language interpreters to better serve them. Our speaker today is Jorge Ungo, Southwest Region Manager for Pacific Interpreters. In this role, Jorge consults with health and social service organizations throughout the southwestern United States on how to design and implement cost-effective yet highly efficient language access programs. Prior to joining Pacific Interpreters, Jorge spent almost a decade working in guest relations at the Walt Disney Company and managing a small finance business. From 2002 to 2007, he was responsible for all business operations of an international interpreting program, including sales and marketing, HR administration, operational logistics, and company-wide training. Today, Jorge frequently presents at regional, national, and international conferences on issues of language access and interpreter evaluation and training. Jorge is president of the Texas Association of Healthcare Interpreters and Translators and a board member and membership co-chair on the National Council on Interpreting in Healthcare. With that, I think we're ready to get started. Jorge, you have the floor.
Thank you so much, Tina. We're going to go ahead and dive right in because we have a ton of information to share with you all today, and I want to make sure that we have plenty of time to get to it all. So let's go ahead and get started. First, I'd like to discuss a little bit of background on who our LEP population is. A lot of times people hear the term limited English proficient, and their assumption is that this is somebody who speaks no English at all. And that can tend to be a bit off. Individuals with limited English proficiency really are individuals who have challenges with communicating effectively in their second or third language, being English. Here in the United States, we have folks that have immigrated from all over the world, folks who speak over 300 languages in their homes. And of these individuals, over 59 million people don't speak English as their primary language. So at home, with their families, with their friends, and their communities, they're communicating with each other in a different language, albeit Spanish, Vietnamese, Mandarin, and 42% of these individuals are what we consider limited English proficient. So we're looking at about 20% of the individuals in the U.S. speaking a language besides English, and about almost half of those individuals being in this limited English proficient category. And again, I really want to underscore that this group of individuals may be able to communicate in day-to-day interactions with coworkers, in commerce, but when it comes to discussing health information, when it comes to discussing legal information, they may be challenged because they're faced with using vocabulary in a second language, in a language that they've learned, that they don't use on a regular daily basis. What we know about individuals with limited English proficiency are that these individuals are more likely to misuse services that are available to them. They're less satisfied with the care that they do receive and are at an increased risk of receiving errors in treatment, either because they don't understand what's being said to them or people that are treating them cannot effectively understand what they're trying to communicate. These individuals are also more likely to misuse prescription medications and not comply with follow-up instructions. And I'll have some examples of that throughout the presentation as we move forward. So let's talk briefly about the legislative piece of this, because I believe that it's important for us to talk about the big picture first, and then we can talk about how you as an organization can effectively serve this population. In 1964, Title VI of the U.S. Civil Rights Act was passed, and it prohibited recipients of federal funds from discriminating against individuals on the basis of race, color, or national origin. And at the time, our country's real focus in passing this law was issues of race and color. But later on in the 70s, a Supreme Court decision came out that found that language is a large component of a person's national origin. And so because of that, language access has become synonymous with Title VI. Discrimination under Title VI includes policies or practices that inhibit equal access to a recipient's programs or activities for individuals with limited English proficiency. So in the eyes of the law, discrimination is not only, doing something to prevent someone from accessing services, but also not doing something, and thereby preventing someone from being able to access services. So not providing information in a way that everyone can benefit from would be, in the eyes of the law, discrimination under Title VI. In August of 2000, President Bill Clinton passed Executive Order 13166. And basically what Executive Order 13166 did is it required that federal agencies that provide funding to give guidance to the organizations that benefit from that funding on how to comply with language access requirements under Title VI. So again, Executive Order 13166 required that the federal agencies like the Department of Health and Human Services, the Department of Transportation, that those federal agencies provide some kind of guidance to recipients of their federal funds on how to comply with Title VI in regards to language access. So in December of that year, the U.S. Department of Health and Human Services, which administers Medicare and Medicaid, published the CLAS standards, CLAS, which stand for Culturally and Linguistically Appropriate Services. The CLAS standards guide recipients of federal funds or recipients of funds from the Department of Health and Human Services on, again, how to comply with Title VI in regards to language access. So who would be covered under these guidelines? Hospitals, nursing homes, private physicians' practices, anyone who accepts even $1 of federal funding, whether it be through a grant, whether it be through Medicaid, Medicare, as long as the organization receives $1 of federal funding, and whether or not that $1 gets used for individuals with limited English proficiency or not, that organization must comply with Title VI in regards to language access. So I want to look at some of the standards that are part of the CLAS standards, and there's about 13 or 14 of them, and we won't have time to go through every single one of them, but I want to point out some of the more important ones and some of the ones that are, according to the Department of Health and Human Services, these are the ones that are mandatory for recipients of their federal funds. Standard number 4 states that organizations must offer and provide language assistance services, including bilingual staff and interpreter services, at no cost to each client with limited English proficiency. It must be done at all points of contact and in a timely manner during all hours of operation. So it would not be appropriate to tell an individual of limited English proficiency that they have to wait 4 hours for an interpreter to come to assist them at a medical appointment. It must be done in a timely manner so that the patient doesn't have to wait any more than a patient normally would wait to access the services. This mandate also states that these services cannot be charged back to the patient. So these services must be made available to the patient at no cost. And that's a really, really important component of this. Unfortunately, this is an unfunded mandate, but again, it isn't something that the patient can end up paying for because of their limited English abilities to communicate. Standard number 5, organizations must provide to clients in their preferred languages both verbal offers and written notices informing them of their right to receive language assistance services. So it's not enough to make these services available, but it's really important to make sure that your organization is informing patients that not only are these services available, but that these services will not cost them anything and that it is their right to utilize these services. Oftentimes we see patients of limited English proficiency bringing family members or friends along with them to medical appointments to be there to interpret for them. And a lot of that comes from historically them knowing that an interpreter wouldn't be provided at their doctor's appointments, or they experienced the same thing with another family member that went on a doctor's appointment and an interpreter was not provided. So again, organizations must provide in those languages a written notice, but also verbal notices and offering an interpreter to the individual. Standard number 6, organizations must assure the competence of language assistance provided to limited English proficient clients by interpreters and bilingual staff. Family and friends should not be used to provide interpretation services except on request by the patient or the consumer. This is a really important standard and something that the Joint Commission has really focused on with their new standards on effective communication. And we're going to talk a little bit more about fluency and heritage speakers and the different levels of bilingualism that we experience here in the United States. But what's important for you to know is that both the Department of Health and Human Services and the Joint Commission are encouraging you and mandating that you ensure that individuals that work in your organization that will be utilized to do their job bilingually or to provide interpreting services should be tested and there should be a mechanism in place within your organization to ensure that those individuals are truly competent to provide that type of service, that level of service. So again, whether it's somebody that's simply doing their job bilingually or if it's somebody that is being utilized as an interpreter, there should be a mechanism within the organization to ensure that that person is bilingual. Standard number 7, organizations must make available easily understood educational materials and post signage in the languages of the most commonly encountered groups. So this is, again, a really important part of the CLAS standards and one that organizations tend to struggle with, primarily because you're probably thinking to yourself, my goodness, how are we going to possibly comply with all of these mandates when we have such diverse populations that we serve within our communities? So the Department of Justice has provided guidance to organizations on how to do a scan, how to do what they call a 4-factor analysis to evaluate to what extent they need to comply with these mandates. And so through that 4-factor analysis, your organization can evaluate what is the community that you serve, what is the proportion of patients that you see that speak languages besides English or communicate primarily in languages besides English, and to what extent do you need to comply. So if in your community you have a large Somali population, but you don't have a large Vietnamese population, even though you may see a Vietnamese patient or two every now and then, your signage doesn't necessarily have to be all in Vietnamese. And that is what the four-factor analysis would help you to determine, is in which languages and to what extent do you need to move forward with some of these initiatives. So again, having signage is something that would be obviously helpful to patients, but you can use your discretion to see in how many languages that signage should be posted. There's also some organizations. The Robert Wood Johnson Foundation a few years ago did a project, and I believe it's still in place, to create universal signage. So this was signage that utilized symbols rather than words to communicate where places were. And they did a lot of research to ensure that the signage would transcend cultures and languages. So making sure that whatever symbol that they used for cardiology would be an effective symbol regardless of where the person came from or how long they've been in the United States. So to kind of take us to the next point, absence of language services may compromise a person's privacy and cause embarrassment or instill confusion and fear. Again, we have seen the model of using a family member or a friend, even using children to interpret for their parents during their medical visits. And so not having some type of a process in place to give that person the privacy that they need to have these kind of open conversations with their healthcare providers can absolutely compromise not only their privacy but also their trust in the institution, their trust in their healthcare provider. And the bottom line is that poor communication equals poor care. If we can't communicate effectively with someone, then we can't care for them appropriately. So it's really important that we have these mechanisms in place so that we can prevent some of those errors that we were talking about and that we'll talk about more here as we move forward. So within the language service industry, folks try to be very clear about the differences between translation and interpreting. And outside of our little bubble, I think people use these terms interchangeably quite a bit. But within the language service industry, the differentiation between translation and interpreting boils down to this. Translation is the written word. Interpreting is the spoken word. So translation is where you are translating a document from one language to another. Interpreting is where you are interpreting someone's speech, someone's words into another language. Sometimes folks have a misconception that interpreting is a summarization or that interpreting is not quote-unquote word for word. And really what we tend to focus on when we discuss either translation or interpreting is meaning for meaning translation, because there will not always be one word for every word that's uttered or that's written. In different languages, we tend to describe things differently. We put the words in different orders when we speak. And so it's not always going to be, again, word for word as people think. Now, that being said, every translation and every interpretation must be accurate. It must be complete. We can't leave anything out. The concept of word for word, which many people correlate with accuracy and completeness, there's a little bit of a disconnect there. There's a really great guide that was published by the National Health Law Program in conjunction with the American Translators Association and the National Council on Interpreting in Healthcare. It's called What's in a Word, and it's a guide to understanding the differences between interpreting and translation in healthcare, and also understanding what the different roles are for interpreters and translators, and more importantly, what the different skill sets are for interpreters versus translators. So this is a really great guide. It's a free guide. It's available on the National Health Law Program's website, which is healthlaw.org. And I encourage you to download a copy of this guide to help you better understand the differences between translation and interpreting and when one might be more effective than the other. Now, this is one of my favorite topics. As Tina mentioned earlier, I'm based in Texas, and in Texas we have a very high percentage of individuals that are, and you can't see me doing this, but I'm putting up air quotes, that are bilingual. And you know, I personally, my parents immigrated to the United States when I was about a year old, and I grew up. My entire education was done in English, but all of my conversations at home were in Spanish. My parents were adamant that it was important that I stay connected to my culture, to my language, and so all of our conversations at the dinner table, everything was always done in Spanish. The only time that I was ever allowed to communicate in English was when my father was helping me with my homework, because it was easier for me to understand the concepts if we were using the same type of vocabulary that was used in school. So that being said, I am what we call a heritage speaker, somebody who learned the language through family, through stories, through culturally, and not in a classroom setting. And we find a lot of that here in the Southwest, and I think it's spreading more and more throughout the United States as generations, second and third degree generations start to emerge. What we have found is that up to 40% of individuals that claim to be bilingual or who think that they are bilingual fail to demonstrate that they are sufficiently proficient in both languages to be able to provide services safely. What we find a lot of times is that individuals may appear to speak a language fluently, may sound like they speak the language fluently, but they simply lack the vocabulary and the cultural context to effectively serve either as an interpreter or even as a bilingual staff person. So again, heritage speakers may have varying levels of fluency and may have gaps of knowledge about their cultural heritage. Just depending on how often the language is used, how immersed they are. I had the opportunity to spend my summers abroad in my home country, and so my Spanish vocabulary may be a little more extensive than some other heritage speakers here in the United States. Nearly 90% of all second-generation Latinos and 94% of those in later generations say they speak English very well, with their Spanish proficiency diminishing. And one of the things that I have learned as I travel around the country and speak to folks that work in healthcare, a lot of times they feel pressure. They feel pressure from their organization, from their coworkers, from the providers that they work with. They feel pressure from them to interpret or to help facilitate communication with someone who is limited English speaking. And so they'll put themselves in situations where they know they're not being effective, they know that they're not helping either party, but because of the pressure that they feel from their coworkers, they feel like they have no choice, and they're constantly being pulled in to quote-unquote translate for the doctor. Working with untrained interpreters. So again, when we look at the Department of Health and Human Services, when we look at the Joint Commission standards, there's two main components that they're focusing on. One is evaluation and ensuring that individuals do have those language skills, and if they're going to be used as interpreters, that they have the ability to interpret. There's a quote that's been going around lately that was said at a conference, and basically they said, just because someone has two hands doesn't necessarily make them a pianist. And it's similar in the language field. Just because somebody speaks two languages doesn't necessarily make them effective as an interpreter. And we'll talk a little bit more about that training that's required and some of the skills that are required to be an effective interpreter. But studies have shown that untrained interpreters are more likely than trained interpreters to make errors with adverse clinical consequences. In fact, they have found that interpreters that don't have that haven't had any training tend to make up to 33 errors per encounter. That's huge, 33 errors per encounter. And some of these errors include changes in the meaning of the message, omitting information, adding additional information. And these types of errors can truly affect, again, not only the outcome of the patient, but also the patient's sense of confidence in the organization and in their healthcare provider. Family and friends who interpret often misinterpret and omit information that's vital to care. What we often see when family members are interpreting is really not interpretation, but they're actually participating in the medical appointment. They're having a direct conversation with the healthcare provider, and in many ways leaving the patient completely out of the message. Using families, friends, minors, volunteers, strangers, other patients, or simply individuals who are not qualified can expose your organization to liability under Title VI. It can result in a breach of confidentiality. Unless somebody understands the importance of their role as an interpreter and the impact that they can have on patient outcomes, a lot of times people may not think about the consequences of sharing information outside of an encounter. Somebody from the community may not have been trained in HIPAA, and so they may not understand how important confidentiality is. And we see this a lot, especially with smaller communities where people tend to talk with each other and tend to know what is going on with other members of the community. It may result in the client being reluctant to fully disclose critical information, may result in additions, omissions, and changes in the content, and it may destroy the power base within the family. Think about families that have a very hierarchical system within their families, or cultures that have a very hierarchical system within their families. And think about what it does when a 12, 13, 15-year-old child is put in a position of power, when that child is the only source that mom and dad have to be able to communicate with the outside world. That's huge. And that can impact a family in ways beyond anything that you or I would see during that particular medical encounter. So what type of training do interpreters go through? Generally, we find that interpreters go through anywhere between 40 to 120 hours of dedicated healthcare interpreter training. And it depends largely on what type of training resources are available to them. Unfortunately, we don't have a lot of university programs for medical interpreting in the United States, so individuals that want to work as interpreters tend to turn to professional associations or training organizations to obtain this type of training. Some of the topics that are included in this training would be information about the laws that relate to LEP access, culture and barriers to communication, and how culture can truly affect a person's ability to understand information and to communicate information. The goals and the function of the interpreter. What is the interpreter's role during the interpreted encounter, and how can the interpreter be present and be of assistance to both parties without being obtrusive, without getting in the way of communication? Facilitating the interpreted session, and this is something that requires a lot of skill. It's being able to effectively guide the conversation so that the interpreter can do their job effectively. So working with the provider to pause at appropriate times so that the interpreter can interpret chunks of information to aid their memory. That would be part of facilitating the interpreted session. But also when a patient starts to open up and starts to express themselves, that would not be a time to stop and ask them to interpret in chunks. So, the interpreter has to learn how to manage these different types of situations and be effective throughout the session. The different modes of interpreting. So one mode would be where the interpreter says the interpretation during a natural pause in the conversation. So the provider, asks a question, "Ma'am, how are you doing today?" Pause, and the interpreter says what the provider just says. Then there's a natural pause. The patient responds. Again, a natural pause, and that's when the interpreter jumps in to say what the patient just said. That is what in our industry we refer to as consecutive interpreting versus what we refer to as simultaneous interpreting, which is basically speaking at the same time as the person generating the message. Something that's used more so in courts, in like the United Nations, that type of style of interpreting. But we do see it used in a healthcare setting sometimes. If an educator is doing a diabetes counseling, a diabetes education class, and there's a mixed group of both limited English speaking patients but also English-speaking patients, then they might utilize simultaneous interpreting to facilitate that and to make things go quicker so that, again, the English-speaking folks aren't affected by the fact that interpretation is being rendered during the session. So modes of interpreting are taught at a very basic level in introductory interpreter training, and then as interpreters begin to specialize in different fields, they usually will seek out more extensive training in these different modes. Memory and note-taking are so important in the work that we do because think about it. We're going to be interpreting words with like 17 letters. We're going to be interpreting dosages, times, appointments, addresses, all kinds of information. So it's really important that interpreters have very good memory skills and that they practice that, but that they also have good note-taking skills. And not only having both of those skill sets, but also knowing how to dispose of those types of notes and that type of information in a way that's HIPAA compliant. 5 hats of the interpreter and the interpreter's code of ethics. In the world of healthcare interpreting, we have come to adopt an incrementally interventional model of interpreting, one in which an interpreter is just a conduit, is just passing a message back and forth during 80% of their encounter, where they are somewhat invisible to the encounter most of the time, where really they are just the voice for the provider and for the patient. But there comes a time when there may be clarification that's needed, or there may be a cultural issue that's preventing the provider and the patient from communicating clearly with each other. And in these instances, it would be appropriate for the interpreter to stop the session and inform both the patient and the provider that they need to clarify something. So whether it's that the interpreter doesn't understand something and needs clarification, or that the provider or the patient may not be understanding something, and the interpreter, by being the kind of intermediary, is the first to identify that. So these are different hats that the interpreter may wear through the session, and how to go from one hat to another is one of the most challenging parts of working as a professional medical interpreter. So this is something that interpreter training courses really spend a lot of time working with folks on. The Interpreter's Code of Ethics. So we have a national code of ethics for interpreters that work in healthcare. This code of ethics was developed by the National Council on Interpreting in Healthcare in 2004. And the Interpreter's Code of Ethics includes accuracy, completeness, impartiality, respect, cultural awareness, role boundaries, professionalism, professional development, and advocacy. One of the 5 hats that an interpreter may wear during an encounter would be that of being an advocate. And it's not a role that we take lightly, and it's not a role that we take on very often, but it is part of our role in ensuring that that patients are receiving the care that they need. We also, I want to mention on role boundaries, a lot of times in the interpreting community, we have many individuals who this is a second, third, or maybe even a fourth career for them. Interpreting and translation was not something that they set out to do from the get-go. And so a lot of times we have nurses, retired physicians that are now working as interpreters. And from a linguistic standpoint, they make excellent candidates because they know the language. They know and by the language I mean the language of healthcare. They know the setting. They understand the system. So in that regard, they make really, really great candidates. But part of our code of ethics talks about role boundaries and making sure that when we are playing the role of an interpreter, that we are only playing the role of the interpreter, and that we're not influencing the encounter in any way based on our own beliefs, our own knowledge, our own expertise, that the interpreter really truly sticks to that role of being an interpreter and doesn't step into the role of being a counselor or being a physician or being a nurse, regardless of what their background is. So when they're being an interpreter, they're only being an interpreter. In addition to having a code of ethics, the National Council on Interpreting in Healthcare also released 32 standards that are grouped under the 9 different ethical principles, giving us a national standards of practice for interpreters in healthcare. So whereas our code of ethics serves as our rules, the standards of practice give us practical ways to implement those rules in our day-to-day work as interpreters. And these standards are also used for training. A lot of organizations are using them to develop guidelines for hiring interpreters, and also for creating policy within the organizations on how interpreters are utilized. So that covers the piece on what type of training an individual would need to get. So, once you've identified someone as being bilingual and being an effective candidate to be an interpreter, they'll need to be trained as an interpreter, so to make sure that they have the appropriate skills to be effective in that role. And then the next step would be to have some kind of mechanism in place to test their competency as an interpreter. And so there are 2 organizations here in the United States that offer national certification for interpreters in healthcare. As of right now, that certification is available in Spanish only, but over the next couple of years, both of those organizations will be rolling out additional certification for other language interpreters. There's also different levels of certification that can be obtained for folks who interpret a language that does not have a test yet. So they can get a lower level of certification that basically certifies their knowledge of medical terminology and their ability to communicate in English effectively. However, certification is not the only measure of someone's competency as an interpreter. So there are tests out there that can be administered, and so your organization doesn't necessarily have to get someone certified nationally in order to be in compliance with federal guidelines. So taking a test through an organization that is not a certifying body would not be a certification. It would simply be an assessment of that person's skills. But both the Joint Commission and the federal government recognize that is, in addition to certification, that type of testing is an appropriate way to evaluate someone's skills. So what type of testing are we discussing? Oral fluency and listening comprehension in English and in the target language. So making sure that the person can not only effectively communicate, speak in the language, generate speech in the language, but will also understand things that are being said in both of those languages. The ability to interpret consecutively with accuracy, completeness, without altering, changing the meaning, omitting information, summarizing. The interpreter should interpret every utterance as it was said during the entire appointment. Medical terminology in both languages is incredibly important, especially in healthcare. But I hesitate to just talk about medical terminology because there's so much jargon that we utilize in the healthcare setting that goes beyond simply anatomy and physiology. So really having that breadth of vocabulary to manage anything. Think about a consent form and all the legal terms that are included in that. Think about the conversations that we may have with patients in regards to insurance or billing, and there's a whole nother set of vocabulary that goes with that. So making sure that whatever vocabulary the interpreter will be using is part of that testing process to make sure that they can effectively communicate with patients and with providers in both of those languages. And then testing them on their knowledge of the Code of Ethics and their knowledge of standards of practice are key components of an interpreter test.